Good morning. Welcome everyone to this last session of the ADPD Congress. And we are going to begin this session. Remember that you can make questions that can be directed to the speakers directly, or you can write your questions via online. And then I am going to replace Dr. Stocky, and the boss of the session and moderator is John Allen, who is also the first speaker. He is CEO of a pharmaceutical company, EIP Pharma, and is going to present effects on cognition and function assessed by CDR-SB of the oral p38 alpha kinase inhibitor Neflamapimod in patients with mild to moderate dementia with Lewy bodies. John.
Thank you, Jamie. I want to welcome everyone to this, last session, but I think it's actually going to be a very good session, and indeed, it's aptly named because I think you will see there are some real advances that the speakers will be talking about. So I'll begin my talk with just thanking the organizers and the scientific community on behalf of the investigators and the study team for the AscenD-LB study for giving us the opportunity to present our quite interesting follow-on results to the AscenD-LB clinical trial. So these are my disclosures. So dementia with Lewy bodies is the second most common neurodegenerative dementia. In every respect, it's at least as severe, and in many respects more severe than Alzheimer's disease. But despite that medical need, there's been a paucity of drug development in DLB. A variety of different reasons, but the major reasons are related to the lack of understanding in terms of mechanisms of disease, as well as having validated assessment tools. And what I hope to do in my talk is actually show you data that with the results in the AscenD-LB in terms of the CDR sum of boxes, we're actually it represents a real advance in both of those arenas. So this is objective to present data on the clinical dementia rating sum of boxes, data in the AscenD-LB clinical study. I think most of you are very familiar with the CDR sum of boxes, and the use of CDR sum of boxes in Alzheimer's disease is very well established and is the primary endpoint in multiple phase 3 studies at the current time. However, in DLB, it's been used very little, primarily in natural history studies, and there's really no published data on a use of CDR sum of boxes in a therapeutic trial. There are a variety of different reasons why CDR sum of boxes hasn't been used, but I think falls into two broad categories. One, in terms of is it specific for DLB versus AD, and what are the features that would make it appropriate while it has been established in AD. And the other one is particularly in phase 2 trials, whether there's enough progression on the CDR sum of boxes to be able to evaluate treatment effects. So in terms of the clinical trial itself and the drug, the background is here. Neflamapimod is an investigational drug, an oral small molecule p38 alpha kinase inhibitor that targets a variety of different in vitro and in vivo data that demonstrated targets the basic mechanisms of cholinergic degeneration in the basal forebrain, which is the primary pathology and driver of disease expression in DLB. The main results have been presented at CTAD from the AscenD-LB clinical trial, which is a phase 2A clinical study, an exploratory study, been presented at CTAD in 2020 and then additional data in 2021. The major takeaways is that there is an effect in terms of the primary endpoint, a cognitive test battery evaluating attention, executive function, and visual learning. The main effect was seen at the higher of two doses that were seen that were utilized in that study at 40 milligrams 3 times a day. In addition, as we presented more data in last fall at CTAD, an effect on the timed up and go test as well. So there's effects on both the cognitive as well as the gait dysfunction and the motor aspects of DLB that have been demonstrated. Just one slide on the science and the mechanism of action in terms of Neflamapimod. We've worked over the last few years in terms of developing the scientific rationale and the mechanism and the mechanistic studies. We've worked with Ralph Nixon's team, Ralph and his team at NYU. This is data that was presented a couple of years ago and is being, we're working on a manuscript to publish this result. But if you look in here, in this transgenic mouse model, if you look at the number of choline-acetyl-transferase staining cells in the basal forebrain and the medial septum, there's a significant reduction relative to wild type, while there's complete restoration with 4 weeks of treatment with Neflamapimod. So again, showing direct evidence of reversing the cholinergic degenerative process in the basal forebrain. So this is the clinical study, 16-week placebo-controlled phase 2A study in mild to moderate dementia with Lewy bodies by the 2017 consensus criteria. But we added, in addition to that they had to be abnormal on uptake on the DAT scan. Importantly, all the patients were on background cholinesterase inhibitor therapy, which is the standard of care in patients with DLB. So this is there were 91 patients enrolled, randomized to placebo or Neflamapimod. After they were randomized, their dosing regimen was either 40 milligrams twice a day if they were below 80 kilograms, or 40 milligrams 3 times a day, the higher dose, matching placebo. The intent of this was the original intent was to match plasma concentrations across the weight spectrum, though as it turned out, the 40 milligram BID, despite being given in lower doses, was still significantly lower in terms of plasma drug concentrations. And as I mentioned earlier, out of this, the major therapeutic effects were seen in the 40 milligram TID dose group, which you will see a little bit in here as well. Otherwise, small number of discontinuations, particularly in the 40 milligram TID group. There were no discontinuations, and we have the CDR sum of boxes in particular. Even with COVID-19, we have a very full data set because we were able to obtain it remotely as well. Here, the baseline characteristics across the board, a very typical early stage dementia with Lewy body patient population, well balanced for placebo Neflamapimod, as well as in the 2 higher weight dose groups, and then on CDR sum of boxes in particular, I'll highlight that well matched. So these are the main data. The first point here is that at both week 8 and 16, if you look at the gray and the blue here, there is nice progression on the CDR sum of box in the placebo group with between 0.6 and up to 0.8 average increase in CDR sum of boxes scores, which goes along with the clinical expression or the impression that all of us have that DLB is a rapidly progressive disease, while with treatment both in the overall group and in the 40 milligram TID group, there's a clear reduced level of progression or worsening on the CDR sum of boxes. The main statistical analyses are shown here. In the first line, in the primary analysis of all randomized patients of the MITT analysis, you can see there's overall, using an MMRM analysis, nearly a half-point difference between placebo and Neflamapimod. I show a p-value as well. This was an exploratory study, but we're showing it just to show the likelihood of the result of the strength of evidence. and a good effect size in this patient population. And then a sensitivity analysis looking at just the higher weight patients where they had an equal chance, again, within that of being on placebo or 40 milligram TID, somewhat greater effect, a lower p-value, and a higher effect size, which goes along with the overall analysis that 40 milligram TID seems to do a little bit better than 40 milligram BID. And then to dig into the domains to understand what's driving it and how well it's aligned to this concept of, is the CDR sum of boxes appropriate for DLB or not? It's actually quite interesting where the results show exactly, in many ways, what one would have predicted. So one thing is that memory, which is Alzheimer's disease more so than DLB, particularly in an early stage population like this, there's very little progression. Where you do see progression is on judgment and problem solving, as well as personal care, which would capture both the cognitive and the motor aspects. And then in terms of treatment effect, the best effect is in personal care, where just using a simple Wilcoxon ranked sum test both at week 8 and 16, there's a significant difference with Neflamapimod treatment. So the last part of the talk, I'll just talk about some additional work we've done after the main study was completed, looking at stratification by baseline plasma phospho-tau181 as a marker of amyloid and or Alzheimer's disease copathology status. Now, this was, when we went into the study, we knew that there was a lot of data out there that patients who have elevated plaque load, their disease course and their disease expression is fundamentally different than patients with pure dementia with Lewy bodies. But doing PET scans on everybody and CSF was just not practical in the time and place. So what we did instead, was store plasma, and this was in now 3 years ago, where the biomarkers, it was clear that we were going to be able to have biomarkers, but they weren't there yet. And so we stored the plasma, and with, in particular, the publication of a paper early last year that demonstrated in DLB, you could use p-tau181 or p-tau181 or 216 to actually predict PET status by tau PET status or CSF amyloid status. We went back and analyzed these samples and used a cutoff, a pre-specified cutoff that the VU Medical Center had set for presence or absence of amyloid copathology, and reanalyzed that data. So at baseline, about a little over half the patients did not have elevated plasma count, or 45% had elevated plasma p-tau. And what you can see, just starting on the placebo, that the CDR sum of boxes score is a little bit higher. It's not significantly higher, but it is higher. But within each strata, well balanced. And then rather remarkable results that the patients without copathology, the low plasma p-tau, good progression in placebo and absolutely flat with Neflamapimod treatment, while the patients with copathology have also progression in the placebo group, but somewhat overlapping treatment. There's no obvious treatment effect, but a very clear-cut difference. So we can talk about this during questions as well a little bit, but overall, the CDR sum of boxes actually does perform very well, and there are a variety of different reasons we believe this, but across the board, it actually seems to match the disease quite well. And in terms of the implications of the p-tau181 data, I think it does advance our understanding of the disease mechanism, because in the end, with this mechanism, it shows well aligning with the mechanism and validates the underlying hypothesis in terms of the cholinergic deficit in DLB. And then, again, it's actually quite impressive how well the CDR sum of boxes works to differentiate the two. So these are my conclusions. Seems to be that CDR sum of boxes works well as a primary endpoint, or could be considered as a primary endpoint. and confirmatory trials of Neflamapimod as a disease-modifying therapy for DLB are warranted.
Thank you, John. We have just one question because we are out of time.
Okay. Thank you for the nice talk. So is the mechanism of action of this inhibitor published?
It has, on a broad level, published. There's a review article that I wrote with one of my colleagues in IGM, the International Journal of Molecular Sciences, in 2020 that discusses it. Most of the work that is so far has been presented at meetings, but the main manuscript is under review at the current time. But the target is, it's via P38, working on a protein called RAB5, which is a master regulator of endosomal transport and endocytosis. And the hypothesis is that it's the aberrant retrograde transfer of NGF and other neurotrophic factors and their receptors that aberrant activation of RAB5 inhibits. And you can restore that because P38 alpha is a master regulator of RAB5 activity. But that review article, if you Google Alum and Gurman,
Okay.
it's actually, we've tried to explain.
Because from looking at the mechanism...
Sorry.
Oh.
Questions after, please.
Just a comment. From looking at the downstream, so it doesn't act on P38 itself, phosphorylation, it works downstream. And P38 has been implicated in the insulin signaling, and the downstream of insulin signaling is JSK3 beta, which is a major kinase for tau. So you would kind of expect that it should work on tau pathology, even if it's extensive.
And that's correct, and it does. We have published in Alzheimer's disease that the drug reduces phospho-tau and total tau levels in CSF. That is published.